to the demo.
This is really good.
Thomas, you know why I chose this image for this topic on the right ventricle? Well, because this structure is usually not considered during echo exams until it's too late. And this happens even though the right ventricle has an extremely high importance because it has an impact on prognosis in several cardiovascular diseases. And is the main protagonist of other diseases, for instance, as pulmonary hypertension. The right ventricle is different because it deals with a low pressure system, it cannot cope with high pressure, and contracts differently.
Okay, Anna, but first we have to show our audience how to image the right ventricle. People are always afraid of assessing the right ventricle because they say it's very difficult. Well, it's not as easy, I agree, but we will show you how we can make it simple and where you can extract the most important information you need, namely, how is right ventricle function and what is the size of the right ventricle. Both issues which are very important in the assessment of critically ill patients and also patients in normal cardiology situations. So Anna, how would you go about in imaging these patients?
Exactly, Thomas. I would start always with a 4-chamber view, but I would actually use a focused atypical view for the right ventricle, which I can easily obtain by moving the transducer more laterally. As you see, I can really better visualize the lateral wall of the right ventricle.
I think this is a very crucial step, and this is the first trick that I would strongly recommend to you. Why? Because you have a better orientation of the ultrasound beam with the free lateral wall of the ventricle. So now you're more perpendicular, which gives you more echoes and which allows you to see the right ventricle much, much better. Now, in him, we get good image quality even in a normal 4-chamber view. But in many individuals with this slanted view that Anna is showing you right now, you would get a much, much better view.
Yes, Thomas, and when we want to measure the ventricle, it's extremely simple. We get a nice view where we see 2 leaflets of the tricuspid valve opening. We freeze it, and we simply measure the distance between the septum and the lateral wall.
So pretty much at the same level that you would measure the left ventricle.
Exactly.
There's only one little problem that you might have if you put the transducer too far cranial. You can sometimes have measurements which overestimate the size of the right ventricle. So be sure that you don't foreshorten the ventricle.
Exactly, and the same is you really have to rotate the probe the right way, otherwise you
Yes, exactly.
increase the size. And another important thing is to look at function. So actually, the right ventricle, in comparison to the left ventricle, moves more using the longitudinal contraction, where the left ventricle uses more the radial contraction. So we really should look at the movement in systole and diastole of the tricuspid annulus. We can make it visually. When you really have big excursion of the annulus, we can say the function is more likely good.
Yes, but there's a way where we can really measure this longitudinal function in a relatively simple way.
Yes, we use the same excursion of the annulus, but we use the M mode. So we place our cursor and we make sure the ventricle really moves and the annulus moves towards the cursor. So maybe you have to optimize your image like this. And then we use the M mode function and we see the excursion of the ventricle. We can also measure. You follow the same line, and here, measuring the distance, we will have 19, which is a completely normal value.
Yes, and the interesting thing is that the right ventricle has higher values as the left ventricle. So the so-called mitral annular plane systolic excursion is less than the right excursion of the right ventricle, which just confirms what Anna said, that the right ventricle moves more in a longitudinal direction. So to summarize some of the key points that we just saw, first of all, use a focused right ventricular view, measure at diastole, don't be too far cranial with your transducer, and when you look at systolic function of the right ventricle, don't forget it contracts differently, more in a longitudinal direction. Now we're going to summarize the different views where we can image the right ventricle, this time on the simulator.
It's extremely essential to look at right ventricular function and size. I will teach you now a few views which allow you to assess the right ventricle. First, we start with a personal long axis view. It's a view you are familiar with, but this view doesn't really allow you to assess the right ventricle because you only see the right ventricular outflow tract. The short axis view instead tells you more, because whether you are at the base or at the apex, towards the apex, you can really get more information. Here at the base, you can appreciate the inflow, outflow of the right ventricle. You see, starting from the tricuspid valve, going to the pulmonic valve, and in the mid-ventricular space, you can see that the right ventricle has this normal crescent shape, and this means it doesn't have overload and doesn't cause overload for the left ventricle. Definitely, I would use then the apical four-chamber view, and I would go with a transducer from lateral to medial, but when you stay lateral, actually you can really appreciate better the left ventricle. Here with the simulator, I can tell you it's more difficult. I need to get used to it. And there's another trick you can use when you assess tricuspid regurgitation. You can move the transducer cranially, make it closer to the tricuspid valve, and really appreciate the jet from tricuspid regurgitation. So really a lot of views to get size and function of the right ventricle. But there's another view, right?
Yes, Anna, and I know you're going to show us. Now, we would like to also show you an additional view that I would recommend, especially if you don't have good image quality from an apical position, which is the subcostal view.
Exactly. It gives you a lot. Please turn on your back and relax muscles.
So you've seen the subcostal view on several occasions. Now we'll again just focus on the right ventricle. And the nice thing is that the right ventricle is good to visualize, and you can assess not only the thickness of the wall, probably better than in any other view, but you can see the size very nicely.
Yeah.
And obviously also the function. You see it's relatively close to the transducer, right under, or let's say above the liver.
Announcement system.
And this, I think, is a good view.
I think you can really compare the right ventricle with the left ventricle and see how big it is in comparison.
So this obviously is a normal individual, but if you would have a patient who had, for example, acute pulmonary embolism, you would see a rather large right ventricle, sometimes even larger than left ventricle. So just the comparison alone between the left and the right ventricle can give you a clue to an enlarged right ventricle.
So two key points here. Use the subcostal view because it allows you to assess size and function as well, and compare the right ventricle with the left one. But now, back to theory. Conditions which cause pressure overload, volume overload, right ventricular myocardial dysfunction, or a mixture of the three can lead to scenarios like this one. Look at the right ventricle and compare it with the left one. It's the biggest chamber of this heart. It's extremely dilated and hypertrabeculated. You see it, the myocardium is hypertrophic, and when you consider the motion of the free wall, well, it is reduced. It means this heart, as far as the right ventricle is concerned, is pumping poorly. Do you think it's difficult to assess right ventricular size and function? Well, sometimes it is, because we also have less impressive cases. But to make a diagnosis, you have to memorize 3 points. Look at the size of the ventricle, assess function, and look at the interventricular septum. When we talk about the size of the right ventricle, we mean that you have to measure as we showed you in the demonstration, and the measure has not to be above 35-40 millimeters. So for instance, let's go and have a look at these examples. Here on the left, we have a dilated right ventricle. We see it because of the diameter, and we understand it also because it's so dilated that the tricuspid leaflets do not coapt anymore. In this case, we would expect a big regurgitant jet. On the other side, we have instead a normal right ventricle, smaller than the left one, so completely normal. And here's a question for you. Which of the following right ventricle you think is dilated? Well, maybe it's easier to say that the one on the right side is dilated, but actually it's both of them, because when you consider the one on the left, it's still bigger than the left ventricle. So this is also dilated. When we want to assess function, well, you have to look at the longitudinal motion of the free wall of the right ventricle, because the right ventricle contracts differently, uses this contraction instead of radial contraction, which is typical for the left ventricle. And here, as you see, this motion is reduced. Look, for instance, at the example on the left, where the right ventricle, apart from being dilated, is not functioning good because this motion of the tricuspid annulus during systole and diastole is reduced. This is what we call TAPSE. It will come later. And the same on the right side, where we have a dilated heart, but a right ventricle, which is functioning better. So this excursion is more preserved. Here are some other examples. We have a relatively small right ventricle on the left with a relatively preserved function, and on the right, again, a dilated ventricle, which is moderately reduced in function.
So let's put everything together that Anna just said. Here is another example. This is a patient where you can definitely see that the right ventricle is dilated, again, compared to the left. You see that function is poor. The patient even has some degree of pericardial effusion. Now, if you do not have the clinical information, it's very difficult to understand why the patient has these findings. But if I tell you that he came in because of chest pain, because he had deep vein thrombosis, and we found an elevated D-dimer, well, then the diagnosis is quite clear. Most likely, this is pulmonary embolism, and that's also what we found in CT. Here we have all the typical findings. The elevated pressure that the patient has to pump against now led to a dilatation of the right ventricle and to poor right ventricular function. So you can see echocardiography can help us diagnose pathologies if we understand how the ventricle reacts to such situations. Let's go to the next example. Here is a patient, again, with a dilated right heart. I think everybody can appreciate that the right heart is larger than the left heart. In this case, we have these strange echoes here, which are pacemaker leads. We do not have right ventricular hypertrophy. The wall is relatively thin, and we do have poor right ventricular function. Now, in this setting, the likelihood of tricuspid regurgitation, I guess, is very high. And here's another case. This time, again, a 4-chamber view, which is optimized for the right ventricle. And if you look closely, you will see again that the right ventricle is dilated and function is very poor. The wall is not thickened, though. Why does the patient have this? Well, again, we need the clinical information. We know that the patient had an inferior infarct. So this is clearly a case of a right ventricular infarct, which is in combination with the RCA occlusion. So important information, poor right ventricular function in the setting of myocardial infarction, as we already learned in the previous chapters, is something that reduces the prognosis or causes a poor prognosis of the patient.
Yes, but function, as we told you, is also measuring this TAPSE, so this tricuspid annular plane systolic excursion. We do it with the M mode, as you see here, and the normal value is above 16 millimeters.
Let me show you exactly how you measure here. So you would kind of put the M mode tracing here into the annulus of the tricuspid plane, and then you get these excursions here, and you would simply measure from here to here. This distance is the so-called TAPSE, and in this case, we get a value of, I guess, 17 or so, so above 16, a normal TAPSE. And here's an example of a patient who has a reduced TAPSE. You see that these excursions are much less. Again, we'll measure from here to here, and the value is definitely below 16. An example of a patient with reduced right ventricular function. It's a nice way of looking at it. However, be a little bit cautious because it doesn't always work, and there are situations where it is also technically difficult to do. When you assess the right ventricle, use your eyeball the right ventricle, use these measurements in conjunction, and don't forget there's a number of different ways to look at the right ventricular function as well, but this is something we'll show to you if you then book the advanced course.
So now that we talked about the first point, measuring the right ventricle, second point, assessing its function, let's deal with the third point, looking at the interventricular septum. Why should you focus on this part of the heart? Because when the pressures in the right ventricle exceeds the pressures in the left ventricle, the septum moves towards the left ventricle and gives a D shape to this chamber. And I'll show you an example for this. Here it is actually. So an extremely dilated right ventricle, which is dealing with pressure and volume overload, and the septum, which gets flattened, moves towards the left ventricle, and this last structure gets the shape of a D. Here are other examples. This motion towards the left ventricle can be less impressive. So here, for instance, in the example on the left, but still this paradoxical motion of the septum, as we call it. And also on the right side, we have this, but as you can see, it's not
as pronounced.
So
the key message here is that the D shape can have all sorts of, I would say, severities. It can be very discrete, but it can be also very massive. And it correlates quite nicely with the pressure in the right ventricle, but not always. But for you to remember, look at the shape of the left ventricle. If it's not round, but more in a D shape, suspect a disease of the right ventricle, most likely pressure, but it sometimes can also be volume overload.
When we assess the right heart chambers, we have also to look at tricuspid regurgitation and systolic pulmonary artery pressure. And you have to know that tricuspid regurgitation, volume overload, and right ventricular dysfunction are strictly connected. Tricuspid regurgitation, as a matter of fact, is a cause itself of volume overload. And when you have volume overload, this will increase the degree of tricuspid regurgitation, which will lead to volume overload again. So like a vicious cycle, you will end up with right ventricular dysfunction and right heart failure. So now let's assess tricuspid regurgitation in a patient.
Here's a patient with a pacemaker who also has tricuspid regurgitation. And we're going to use her to quantify TR.
Yes, what I do is, at the beginning, I optimize my image because I want to see the valve.
Right, because if you see the valve nicely, that's usually where you also get the best color Doppler signal.
Yes, and as a matter of fact, when we put a color, we already have a significant jet, so maybe the position is good.
Yeah, you move up and down, you scan the entire valve, very similar to the mitral valve. It looks like the jet sprays a little bit, but you focus on the proximal portions. Okay, maybe try to image from an intercostal space further up and down.
Usually it's a good trick to get a wide.
Yeah, here you see it. See, this is a very good trick. And looking at all these images, how severe do you think TR is?
We can say it's at least moderate to severe.
I would agree completely. Yes. And here are some examples where you could find tricuspid regurgitation. Patients with pulmonary hypertension. You can see that pulmonary hypertension led to a dilatation and dysfunction of the right ventricle, which causes this massive TR here. This is a patient who has a left heart problem this time, actually mitral stenosis, as you now well can appreciate. There's doming of the anterior leaflet, and this causes what we call post-capillary pulmonary hypertension, which again dilates the right ventricle and leads to tricuspid regurgitation. And here we also have a left heart problem, a patient with aortic stenosis, probably with diastolic dysfunction, also pulmonary hypertension, and then eventually also tricuspid regurgitation, which I think you will agree is maybe moderate. And finally, very frequently will we see it in patients who have left ventricular dysfunction. This is a patient with dilated cardiomyopathy, poor left ventricular function, and a dilated left atrium. Again, the patient probably has pulmonary hypertension, and as a consequence, he develops tricuspid regurgitation. So in all of these cases, the tricuspid valve does not really have a structural problem. It's all what we call secondary or functional tricuspid regurgitation. The right ventricle has a problem, and as a consequence, the valve is incompetent. One last example, a patient who had tricuspid regurgitation following transplant rejection. This is a transplanted heart. Left ventricular function is poor. Again, the patient develops pulmonary hypertension and tricuspid regurgitation. Now, there's one last thing we have to look at. We know that a patient has tricuspid regurgitation, but we can use tricuspid regurgitation to quantify pulmonary artery pressure. And pulmonary artery pressure is a very important parameter in cardiology because it reflects the symptoms of patients and also prognosis and helps us with how we can treat patients. So to know what pulmonary artery pressure is very, very important. And now we'll show you how to quantify it. How do we do it? Very simple. We just look at the TR jet velocity. The velocity can be measured with the help of continuous wave Doppler. So we look at the peak velocity of that jet, and then we simply plug it into a formula. This formula goes like this. You take the TR velocity, square it, and multiply by 4. This would give you, for example, a value of 36 if you have a velocity of 3 meters. 3 squared is 9 times 4 is 36. Now, this might sound very complex, but in reality it's not because the machine does it for you anyway. So all you need to do is measure the velocity, and on the screen you'll get this, what we call gradient. Now, this gradient still doesn't give you the pulmonary pressure. What you now need to do is you need to add the right atrial pressure. How do we get the right atrial pressure? We estimate it. We can estimate it from the size and the fluctuations of the inferior vena cava during inspiration, but to make things short, it's somewhere in the range between maybe 5 and maybe 15 millimeters of mercury. So you add this value to the value we gave you before, so the 36, and so that would give you what we call the systolic pulmonary artery pressure. Might sound complex, but if you do it several times, you will easily understand how it works, and it will give you very valuable information.
Okay, so much for theory, but how do we get a good TR signal in order to measure? We will show you in a demo. And how do we know whether the patient has pulmonary hypertension?
Well, by determining the systolic pulmonary artery pressure, which we do by looking first at the continuous wave Doppler spectrum. Okay, so the velocity fluctuates a little bit. So we have a velocity of maybe 2.5 meters, which means we have a gradient between the right atrium and the right ventricle of 25 millimeters of mercury. And now what we need to do is
we move to the subcostal approach because we need to assess right outward pressure, and we do it by using the inferior vena cava as far as diameter and degree of collapsibility are concerned.
Okay, here's the inferior vena cava. This is the diameter, 12, 13, so that's quite normal. Now we want to see what the collapsibility is, and to assess that we have to have the patient to inhale or actually sniff. Okay, and see what happens. It collapses completely. Okay, so what does that mean?
It means that the pressures in the right atrium cannot be more than 5 millimeters of mercury, and when we add this value to the previous one, 25 millimeters of mercury, we get a maximum of systolic pulmonary arterial pressure of 30 millimeters of mercury.
So normal pressure.
But now let's practice with a clinical case and assess systolic pulmonary artery pressure in this patient. So we've placed the continuous wave Doppler on the tricuspid regurgitant jet, and we've got this velocity. The peak velocity is 3 meters per second, which corresponds to a transvalvular gradient of 36 millimeters of mercury. To this value, we need to add right outward pressure in order to get the SPOP. How? As Thomas said, we need the inferior vena cava. And here it is. We have to look at its diameter and collapsibility with respiration. Here we have a dilated inferior vena cava, which is 25 millimeters, and its collapsibility is reduced. It's less than 50% with inspiration. When you consider this table, you can assess and estimate better right outward pressure with these two factors, diameters and collapsibility of the inferior vena cava. We had 25 millimeters with less than 50% collapsibility. So I would add to that 36 millimeters of mercury at least 10 millimeters of mercury as right outward pressure. The value we get is 46 millimeters of mercury of SPOP. And would you worry with this value? Well, actually, when you assess velocity and transvalvular gradient, as the guideline says on pulmonary hypertension diagnosis and treatment, you can suspect pulmonary hypertension. So our patient, for instance, had a velocity which was 3 meters per second with a gradient which was 46 millimeters of mercury. So for him, the likelihood of pulmonary hypertension is there. We could define it possible candidate to have pulmonary hypertension. For sure, we would now find out what the cause is.
So to make things simple, look at the TR velocity in these 4 examples. Which patient do you think has the highest pulmonary arterial pressure? I guess you will all understand that the patient with the highest TR velocity definitely has the highest pulmonary arterial pressure. And let's look at the corresponding ventricles. Which of them has the worst right ventricular function? Well, not all of them are normal. The correct answer is this one. This one not only has massive TR, not only poor right ventricular function, but that is also the ventricle that has the highest TR velocity and therefore the highest pulmonary pressure. And you can understand that this patient definitely has TR because he has pulmonary hypertension, and he has poor right ventricular function because he has pulmonary arterial hypertension. So in summary, if you put all this information together, SPOP is very important. You have to ask yourself why pulmonary arterial pressure is elevated and do further evaluation if you see elevated pressures. Put all this information to clinical context together with TR and with right ventricular function and with the clinical picture, of course, as well. Now, in conclusion, we want to show you one last case that I think is very important, especially if you work in an emergency setting.
So 29-year-old female who has dyspnea for 3 days and fever. She's diagnosed with pneumonia Her oxygen saturation is 89% and blood pressure is 90 with 55 millimeter of mercury. She's brought to the hospital, and here her ECG shows these T waves, which are inverted and flat in V2 and V3 as a sign of right ventricular strain. The chest X-ray actually doesn't say a lot. Maybe there's a prominent pulmonary artery.
Definitely, it doesn't seem as if there's an infiltrate pneumonia present.
Exactly. And this is her echo. So you can see she's tachycardic and her right ventricle is dilated. Function is also somehow reduced. And again, you can see the short axis. Remember about the paradoxical movement of the septum, which is moved which is moved towards the left ventricle, and it has a T-shape.
When we look at these two echo images, immediately I think most of you will probably get the diagnosis correct. We've got definitely a right heart problem in the setting of a patient who has low oxygen saturation, which was probably falsely diagnosed with pneumonia. In addition, we see that there is some degree of pericardial effusion, and the pattern of most of the septum clearly points to a right ventricular pressure problem. Anna, what do you think the problem is here?
Well, I think it's pressure overload, and measuring the SPAP confirmed it, because the velocity is also here around 3 meters per second.
It's definitely elevated, especially elevated if you consider that it's a young individual. Still, and this is, I think, one of the most important key points to remember, if you have acute pulmonary embolism, and this is what the patient actually had, you will rarely find very high pressures. Why? Because the right ventricle is not conditioned to generate such high pressures. Only if the right ventricle has chronic pressure overload can he generate pressures sometimes even above systemic pressures, 80, 90, even 100 millimeters of mercury. So in pulmonary embolism, don't expect the patients to have very high pulmonary pressures. The problem is there that this acute event of pulmonary embolism is something that the right ventricle cannot cope with and cannot generate these pressures. And what happens and what we're afraid of is that the right ventricle fail and that the patient will get into cardiogenic shock.
And the diagnosis was confirmed with CT. You can see in the two branches of the pulmonary artery there are several thrombi. So this was a case of pulmonary embolism.
And it clearly shows how echocardiography is important in assessing these patients. Now, if you have small pulmonary emboli, you will not see anything with echo. But if the patient has a massive pulmonary embolism, you will. So I think in summary, we can conclude this chapter with just a general conclusion.
Yes, so when you want to assess right heart chambers, use the 4-chamber view and the subcostal view. Look at size, function, and position of the interventricular septum. Combine findings with the clinical presentation. Look at the causes of right ventricular dysfunction or dilatation, which are volume overload or pressure overload, such as in cases of pulmonary hypertension or pulmonary embolism, as we saw. Measure the SPAP and consider that causes of dysfunction of the right ventricle can also be the infarct.